Chapter 30 is talking about bowel elimination and care. It talks about how some nurses may view assisting with bowel elimination as nurses' aid work and low on the list of nursing priorities. However, understanding the importance of proper bowel elimination and the extent to which it can affect how a patient feels cannot be overstated. It talks about normal bowel elimination. Bowel elimination occurs after nutrients are moved through the gastrointestinal tract, the GI tract, also known as the alimentary canal. This process begins in the mouth and ends as the waste products are eliminated as feces or stool via the anus. The process of bowel elimination is known as defecation. It talks about the anatomy and physiology connection. Can you all describe the digestion process? Can you all describe the digestion process or and the organs that food passes through, the whole process? When I think about the digestive process, I tend to compare the mouth to the anus to a straw. Pretty much what goes in that straw must come out that straw. Okay. When I think about the digestive process, I think about food entering the mouth. You begin chewing the food in your mouth. Once you are chewing the food in your mouth, the food passes the epiglottis, um, and the food propels through the esophagus, where it passes the esophageal sphincter, and that sphincter opens and closes, and the food actually enters the stomach, where it's mixed with different juices, different fluids, gastric juices, to form chyme, and chemical breakdown occurs. The chyme and digestive juices, they pass into the small intestines. And in the small intestines is where most absorption began to occur. Um, the liver began to produce bile salts, which emulsify the lipids, aid in their digestion and absorption. The gallbladder began to store, concentrate, and release bile. And of course, the pancreas produces digestive enzymes and bicarbs. In the small intestines, the chyme is more so liquidy, and as it travels to the large intestines, um, the stool become more so formed because water is being absorbed from the waste in the large intestines, and then it passes into the rectum and out the anus. And that will typically be the digestive process. Okay. Aiding in digestion, um, peristalsis aids with digestion because peristalsis cause like a rhythm like wave like movement to help the chyme, to help the waste propel through the digestive tract. It talks about how voluntarily control over elimination occurs between the ages of 2 and 3. It talks about the frequency of bowel movements usually decrease um, as we age. Peristalsis decreases as the individual ages, making elderly individuals more prone to constipation. They are at higher risk for constipation due to decreased peristalsis. And the peristalsis is that rhythm-like wave that's helping food or chyme waste pass through the intestines. Talks about the goal of your elimination care is to maintain the patient's normal frequency, pattern of bowel elimination, or as close to it as possible. At the very least, you must make certain that patients has a bowel movement at least every 3 days to prevent constipation. So individuals should have a bowel movement at least every 3 days. Okay. And the book talks about the timing of elimination. If an individual ignores the reflex and put off going to the bathroom for a bowel movement until a later time, the stool remains in the intestines longer than necessary and can become dry, and hard, contributing to the development of constipation. It talks about the characteristics of feces. The characteristics of stool includes the color, the shape, the consistency, the odor, and the frequency. When a disease process is occurring in the GI tract, the changes in the characteristics of stool may provide clues to the medical diagnosis. Okay. Um, and that's pretty much meaning like some patients with liver disease or liver issues, their stool can look a clay color, kind of a brownish clay appearance. It talks about the normal characteristics of stool. The typical stool is soft, form, light yellowish brown to dark brown, and falls into slightly curved shape. It talks about how food can affect the appearance of the stool. You know, if you eat in green leafy stools, green leafy foods, it can turn your stool into greenish looking stool. It talks about ingestion of iron supplements, how ingestion of iron can cause your stool to be very dark brown or even black. So if you have a patient who is on iron supplements and they complain to you, hey nurse, my stool is black. That is a normal finding due to the fact the individual is on iron supplements. The book talks about abnormal characteristics of stool. It informs you if stool is held in the body longer than usual, the stool may be a harder consistency and be passed in smaller balls or clumps rather than a softer, longer curved shape. If transit time is extremely short due to increased peristalsis, little or no water will be absorbed, and the stool will be liquid or semi-liquid. And in an event, an individual has watery stool several times in a day, then we will classify that as diarrhea. And it talks about the normal and abnormal characteristics of stool on this table. So it's something good to look over. And of course, looking at this, if you see pus in stool, it should make you think infection, or if you see fat, it can be a sign of infection, or mucus, which can be a sign of infection. And it also talks about abnormal findings in a stool would be frank blood, as far as seeing visible blood. That's what frank blood is. You're seeing blood that's visible to the naked eye. Occult blood isn't considered normal as well, where occult blood is hidden or not visible to the eye. And the way that we would detect clot blood is by administering the Guaiac test. The Guaiac test or a clot blood test will actually test for hidden blood in a stool or blood that's not visible to the human eye. And it talks about the significance of abnormal colors and appearances of stool or feces. It talks about how steatorrhea is considered undigested fat. That wouldn't be considered normal if an individual is passing steatorrhea. It points out individuals with ribbon-shaped stool may indicate compression of the colon by a tumor. If you have a tumor growing inside the stool, it may actually growing inside the intestines. It may actually change the form of the stool, where the stool appears as a ribbon shape. That may be an indication of cancer. And even black and tarry looking stool. When you see black and tarry looking stool, you want to think there's a possibility the individual is having a bleed in the stomach. That black and tarry stool is known as melena. Okay. Then it just talks about data collection when patients are complaining of GI issues. Some of the assessment questions to ask about the GI tract. What are some questions you can think that you should ask an individual about their GI tract? For some of the questions I can think, hey, when was your last bowel movement? How often are you having bowel movements? What is the appearance of your bowel movements? Where we ask, subjective questions. And some of the questions we ask, we definitely want to tell a patient complaining, oh, nurse, it was blood in my stool. You want to tell the patient, hey, if it occur again, I would like to see it. But of course, you want to report that subjective information to the physician. Some of the other questions you want to ask, where patients complaining, oh, I feel like I'm having heartburn. I'm having epigastric pain. Hey, when do it start? What relieve it? What triggers it? How long do it last? Different types of questions are necessary for different concerns or different issues. Patient complaining of abdominal pain. Where is the pain located? Okay, how do the pain feel? Is it sharp? Is it burning? Is it throbbing? Do it feel like pins and needles? That type of thing. Okay. And it talks about focused assessments. As future nurses, you all will do head to toe assessments. And again, a head to toe assessment is necessary for your patients who are brand new to the facility, a new admission. You want to do a head to toe assessment where you are assessing the patient from head to toe, where you are looking, you are listening, you are touching, that type of thing, and you are reporting abnormal findings to the physician. There are some situations that require a nurse to do a focus assessment. And a focus assessment, instead of me assessing your entire body, since you complained of chest pain, hey, I want to assess your cardiovascular system. I want to assess your respiratory system. Since you complain your stomach hurt real bad, I want to do an abdominal assessment. That's a focused assessment where I'm focused on one specific system or specific systems. So the book talks about what a focused assessment, how the first thing we want to do when we are doing an assessment is assess. I have a picture up of the abdominal cavity. And with the abdominal cavity, if I'm doing a focused abdominal assessment, I will stand over the patient. I will actually have the patient lying flat, maybe their head on a pillow, and I will expose the abdomen. The first thing I would do is inspect, where I'm looking around the abdomen. I'm looking around the abdomen. After inspection, and part of inspection is looking for different abnormalities, skin tears, surgical wounds, tattoos. You're looking at the shape of the stomach, the contour of the stomach. Um, After you inspect, you will auscultate. And typically, while auscultating, you are following the bowel sounds. You are following the bowel sounds, and while auscultating, you are you typically will use the stethoscope, the big piece of the stethoscope, which is the diaphragm. And it's best practice before using the stethoscope to clean it off with alcohol. Afterwards, clean it off with alcohol because it's best practice to place the stethoscope on direct skin. So the big piece of the stethoscope, which is the excuse me, is the diaphragm. You will begin listening to the right lower quadrant. The right lower quadrant. You will listen in this area. And while you're listening, for bowel sounds. You're auscultating for bowel sounds. And in the event you don't hear bowel sounds in the right lower quadrant or any quadrant, you need to listen to that location for about 3 to 5 minutes. But tracing the bowels, you will start at the right lower quadrant, go up to the right upper quadrant, listening, go over to the left upper quadrant, and last you will go down to the left lower quadrant. It's 4 quadrants of the stomach, and again, you will start right lower quadrant, right upper quadrant, left upper quadrant, and the left lower quadrant. And then you can percuss, where you kind of tap, putting your hand on the abdomen, and you taking the two fingers from the opposite hand, and you tapping pretty much over the middle finger, where you're percussing, you feeling for different organs, you feeling for movement, you listening for sound. Do it actually sound dull over the abdomen or more of a tympanic sound? And you will actually expect the abdomen to have more of a tympanic sound. A dull sound will not be considered normal. And again, your assessment requires you to inspect, auscultate, um, percuss, and to palpate. And palpate is where you are feeling around the different quadrants, where you are lightly kind of digging in those areas with the pads of your fingers around the different quadrants to actually see, do you feel anything abnormal? That type of thing. Are you palpating and feeling the liver, which would be considered abnormal? And you can deeply palpate, where you are digging deep into an area. And what are the things with inspection? Just to say, if you have a patient complaining of right upper quadrant pain and you are doing an abdominal assessment, that area will be the last area I will palpate. If you doing your assessment, you palpating, this will be the last area I will actually palpate, because if you actually palpate in that area and it caused the patient enough pain, the patient actually may refuse the rest of the assessment. Okay. And it talks about vowel sounds and their significance, where it informs you normal vowel sounds are about 5 to 30 gurgling sounds per minute, while the vowel sounds can be considered normal, hypoactive, hyperactive, or borborygmi. And with normal vowel sounds, again, it's 5 to 30 gurgling sounds per minute in a specific quadrant. Hypoactive vowel sounds, we know hypo means it's low. Hypoactive vowel sounds is lower than 5 um, gurgling sounds in a minute. Hyperactive vowel sounds is greater than 30 gurgling sounds in a quadrant per minute. And borborygmi is excessively loud gurgling sounds. And an excessively loud gurgling sounds may be an indicator of hunger, or if not hunger, it can indicate bowel obstruction. And typically, when there is bowel obstruction, you listening to the bowel sounds, you're starting with the right lower quadrant, working your way up to the right upper quadrant, right, the left upper quadrant, left lower quadrant. Typically, when bowel sounds, there is some type of obstruction in the bowel sound. It would proximal to the obstruction, you would hear hyperactive bowel sounds. So just to say, if the right upper quadrant has some type of blockage, everything behind or that comes before the right upper quadrant, which would be the right lower quadrant, will probably sound hyperactive. Proximal to that area, the bowel sounds will be hyperactive. You will hear hyperactive bowel sounds. The book talks about alterations in bowel elimination, and alterations are changes. The most commonly seen alterations in bowel elimination include constipation, fecal impaction, diarrhea, and fecal incontinence. It talks about constipation. A patient with severe constipation may complain of loss of appetite, known as anorexia, as well as bloating. Elderly people who are not physically active are especially prone to constipation. It talks about factors that contribute to constipation. What factors can you think of that actually contributes to constipation? I know decreased activity level can contribute to constipation, where individuals not moving around as much. You're not moving around as much. Talks about changes in food intake, where an individual is not consuming enough fiber. And we know fiber works as a laxative. Fiber has an impact on peristalsis. Decreased fluid intake can contribute to constipation. Medication side effects. There are medications where side effects are constipation. Some of the opioids, the narcotic pain medications, um, iron supplements can contribute to constipation. You know, and even thinking about constipation, you think about the education a patient will require. Surgery can contribute to constipation. And typically, surgery can contribute to a paralytic ileus. How it talks about how pregnancy can affect or can be a contributing factor to constipation, as well as depression, because depression can present in many different ways, but where depression is slowing the body processes. The aging GI tract is at risk for constipation, and it talks about overusing laxatives can contribute to constipation, where some people overuse laxatives, and more so the elderly population. The elderly population began to abuse laxatives due to the fact um, they become constipated, and they become constipated for several reasons. So I think, or actually a rebound effect of overuse of laxatives is constipation. And of course, nerve damage or some musculoskeletal issue, that type of thing, it can contribute to constipation. And it talks about nursing interventions for a patient with constipation. What are some nursing interventions you can think of that can help prevent constipation? What are some nursing interventions that can help prevent constipation? And the book tell you increase activity. Hey, you probably should move around a little more, do some exercise, that type of thing to prevent constipation. Drink more fluids. if it's acceptable for you. Drink more fluids. Increase your fiber intake. We know fiber works as a bulk laxative. You know, and it talks about, certain medications. If you are on certain medications that's contributing to constipation, communicate with the physician. Ask the physician what are some things that maybe are non-pharmacological that would be considered acceptable. And then sometimes we have to put patients on stool softeners if we know they are at risk for constipation. Okay. And the book talks about how providing privacy for institutionalized individuals can prevent constipation. Because some people, if they don't have privacy, where no privacy is being offered, they may decide, hey, I'm gonna just hold it. I'm gonna just hold it, that type of thing. And the book do provide a list of foods high in fiber. And again, at this point, student practical nurses, you should be learning the different nutrients, vitamins, that type of thing that are inside of every food. What food is highest in potassium? What foods are higher in calcium? What foods are high in fiber? You need to know that. You need to know that so that when you have to educate or when you have to enforce, you are well aware. Let me show you nuts, corn, popcorn, raisins, raspberries, whole grain bread. They all are have high sources of fiber. And repositioning patients often, we should be repositioning patients who aren't able to reposition themselves every 2 hours. Our patients who have some type of cognitive deficit, we should be encouraging them to reposition themselves every 2 hours. You want to encourage every 2 hours repositioning. That will contribute to the prevention of pressure ulcer development, and that helps with peristalsis. It talks about administering enemas. Administering enemas can be used to prevent constipation. It can actually help to relieve constipation. It helps to relieve constipation, and there are several types of enema. Some physicians may order for a patient to receive a tap water enema, a soap sud enema, enema with oil. There are several types of enemas, and it's important to know how to use each enema. And when inserting an enema, one of the better positions is actually putting the patient on a left side, the left lateral side, as well as in Siem's position. Those are the best positions for a patient who is getting an enema. And of course, you want to lube up the enema before actually inserting. And the book inform you when medications does not relieve the problem of constipation, the healthcare provider may order an enema. With an enema, it's important that the nurse know the temperature should be between 105 and 110 degrees. When inserting an enema, the enema should not be inserted no more than 3 to 4 inches. No more than 3 to 4 inches. Okay. It talks about contraindications to enemas. And contraindications for a patient to receive an enema will be rectal surgery, where individual had rectal surgery, ulcerative colitis. And whenever I hear the word ulcerative colitis, I know ulcerative, ulcer just always make me think of open skin, and colitis make me think the colon. like an open sore, ulcerative. Um, but other contraindications to enema will be rectal fissures, rectal cancer, excessive bleeding, that type of thing. It talks about complications of an enema. And one of the complications of enema insertion is a vagal response. And it tells you in red, when a vagus nerve is stimulated, it can drop the heart rate as low as 30 to 40 beats per minute and cause constriction of the bronchioles of the lungs. As you know, a heart rate of 30 or 40 beats per minute is insufficient to support adequate blood pressure and circulation for longer than a few minutes, making it important to know the signs and symptoms to watch for. Okay. And anytime that an enema is inserted into the anus, it can stimulate the vagus nerve. And with stimulating the vagus nerve, that's when a vagal response occurs. That's when the vagal response actually occurs. And with the vagal response, signs and symptoms of the vagus nerve being stimulated is the drop in heart rate. It can be chest pain, shortness of breath, feeling nauseated, that type of thing, pallor. Okay. If the patient complains or exhibit any of those symptoms, it is important to stop the enema. You need to stop the enema if the patient actually complains of any of those symptoms or any clinical manifestations are evident. Remove the tube from the rectum, place the patient in supine position, and you need to assess the patient pulse rate, skin color, and check to see if the patient is diaphoretic. Okay. And you want to call for assistance. And of course, if the oxygen level is low, you want to administer oxygen. Another complication of an enema insertion is perforation of the colon, where you actually poke a hole through the colon, pierce the colon, that type of thing, and which would be a medical emergency. And it talks about fecal impaction. It talks about fecal impaction is a blockage of hard stool. And one of the common causes of fecal impaction is laxative abuse. Typically, patients who experience fecal impaction, they may actually report, "Hey, nurse, I think I have diarrhea," because it appears that they kind of streak their underpants, some streaks of diarrhea. Um, they actually see in their underpants. And typically, what occurs with fecal impaction, you got this hard piece of stool. Some of the liquid stool that's in the intestines kind of pass the hard stool, and it seeps out where it appears as if it's diarrhea. Okay. But nursing interventions for a patient with fecal impaction, there are nurses who are required to digitally remove the fecal impaction, where the nurse will have to lube up their finger and stick their digital, which is your finger, in the patient's rectum to pull that stool out, to pull some of the stool out. And sometimes the physician may order enema administration following digital the digital removal of stool. And it talks about diarrhea. What is important to know about diarrhea is Diarrhea is loose or watery stool, and the individual will have to have 3 loose or watery stools in a day for it to be classified as diarrhea. Okay. And it also talks about tenesmus, which is a persistent desire to empty the bowel when no feces is present. And it talks about the different factors that contribute to diarrhea, where individuals who are lactose intolerant, um, that will actually contribute to diarrhea. Because typically you find lactose in milk, dairy, that type of thing. Lactose is a sugar. Anytime you hear an os at the end of a word, you want to think sugar. And lactose is the sugar that's found in a lot of dairy. And typically, dairy itself, the calcium, causes constipation. But due to lactose being in it, if you are lactose intolerant, it's actually going to cause diarrhea. Talks about medication side effects. There are medications that contribute to that contributes to diarrhea. Okay. And even anxiety, stress, different disease processes contributes to diarrhea, and even food allergies. Food allergies can cause diarrhea. And it talks about nursing interventions for the patient with diarrhea. It's important to know what are some things a patient with diarrhea is at risk for. What can you think of that a patient with diarrhea would be at risk for? Because I'm thinking this patient um, may be at risk for weakness due to the diarrhea, which may cause dehydration. Patient may be at risk for electrolyte imbalance, where they're losing a lot of electrolytes. Body is not able to absorb much due to the diarrhea. Okay. It talks about an individual with diarrhea. Um, they need to increase fluids. They need to increase fluids. Physician may order a clear liquid diet for the individual, and a clear liquid diet is more it's fluids, more so fluids, clear fluids. When you think about tea, um, apple juice, cola, that type of thing, clear fluids. Physician, and typically a clear liquid diet is ordered so the individual's GI tract can rest. Give the GI tract an opportunity to rest. And tell you when individuals are experiencing diarrhea, do not give them hot or cold liquids because that can actually increase peristalsis. And if peristalsis increase, that's increasing your bowel movements because it's causing your intestines to move, causing that rhythm like motion, that type of thing. And with decreased peristalsis will contribute to constipation because that movement is slowing. And we need movement to help everything pass. It talks about nursing interventions for a patient with diarrhea to administer their medications. If the physician order anti diarrhea medications, administer their medications. And if diarrhea is due to an individual losing their normal flora in their intestines, and the normal flora is more so the normal bacteria, that lives in your intestines. To replace that, you want to offer yogurt. You need to provide perineal care as necessary. Your incontinent patients who urinated or pooped on themselves, you want to provide perineal care. And it talks about fecal incontinence. And fecal incontinence is the loss of the ability, um, the loss of the ability to have a bowel movement, or to know when you're actually having um a bowel movement. And fecal incontinence is the inability to control when you are about to have a bowel movement. And it talks about the different nursing interventions for fecal incontinence. And some of the nursing interventions is promoting skin integrity. And part of promoting skin integrity is keeping the patient clean. When the patient notify you, hey nurse, I pooped on myself, or nurse, I had a bowel movement, I need to be cleaned up. You want to clean them up as soon as possible, or delegate that task to the nurse assistant. It talks about providing emotional support. What emotional support would an individual need who is incontinent of stool? For some people, if this is something new for them, some people who have some type of nerve injury, been in a car accident, or paralyzed, that type of thing. Um, it may be new for them, and they need emotional support the first time you realize, hey, I pooped on myself. That type of thing, you need emotional support. It can be embarrassing. It can be completely uncomfortable. About obtaining a stool um, specimen, and stool samples may be tested. When you have to get a stool specimen for the presence of parasites, parasitic eggs, blood, microorganisms, that type of thing. It talks about patient teaching that's necessary when preparing to collect the stool specimen. Typically, dietary restrictions need to occur 2 to 3 days prior to the specimen collection. And some of the dietary restrictions will be you need to avoid some foods that are red meat, red jello, that type of thing, so it will not affect the results. Some medications and supplements have to be avoided. Alcohol, when I think about alcohol, it increases our risk for bleeding. Alcohol also works as a pain reliever and a depressant, antacids. Several things need to be avoided prior to a stool specimen. It talks about alternative bowel elimination. Certain disease processes and injuries can necessitate that a patient be provided with an alternative form of bowel elimination by surgically creating a bowel diversion. A bowel diversion is the redirection of the contents of the small or large intestines through an alternate exit site made through the abdominal wall. Okay. And it talks about reasons a bowel diversion is necessary. Individuals who have cancerous tumors, individuals who have ulcerative colitis. The ulcerative colitis can damage a portion of the colon, where some diversion need to occur. Diversion actually needs to occur. And once the diversion is brought to the outside of the abdominal wall, that diversion is called an ostomy. And the mouth of the ostomy is called the stoma. And it talks about if the ileum, a part of the small intestines, is used um, for the diversion, it would be called an ileostomy. And if the large intestines or the colon is used, it's called a colostomy. Okay. And the chapter talks about how a colostomy is further divided by its location along the large intestines. And they actually show you different pictures where this is a double barrel colostomy in the transverse area, the sigmoid colostomy, descending colostomy, ascending colostomy, and to follow the trail of the different quadrants, we typically start at the right lower quadrant to follow the trail of the bowels, the right lower quadrant where you will have more so watery stool in the large intestines, and you travel up to the right upper quadrant, the ascending quadrant, where you still have more so watery stool. And as you go over to the left upper quadrant, the stool become a little bit more formed, and as you're going down to the left lower quadrant, the stool is more and more formed. So looking at these different pictures, we know the sigmoid colostomy and the descending colostomy will have more so formed stool, where the ascending colostomy will have more so watery stool. And even if a ileostomy, a patient had to get an ileostomy, we know that will occur in the small intestines. And with that occurring in the small intestines, most of the chyme or the waste that's in the small intestines is more so watery. But as it's traveling through the large intestines at the right lower quadrant is still watery, going up to the right upper quadrant, still watery, traveling over to the left upper quadrant where the water is being absorbed by the large intestines. It's becoming formed, and as it's traveling to the anus, more and more formed. Okay. And it just talks about some of the nursing assessment questions for a patient with an ostomy. And some of the assessment questions, you want to know, hey, why do you have this ostomy? When was the surgery performed? What type of ostomy is it? You want to question everything as a nurse. Anytime that you see something abnormal on a patient, you want to question it. And it talks about assessing the stoma. When you are assessing a stoma, what are you looking for? A new stoma should be pink to red, shiny, and moist. Just like this one, pink, red, shiny, and moist. When you are seeing stomas that are paler, you are seeing cyanosis where it's looking blue or dusky color, it indicates impaired blood supply. And if you're seeing, black deficits, it can be a sign of necrosis. And if you do not see a stoma that's pink, red, shiny, and moist, you want to report that to the physician. And it talks about to determine the correct size that the stoma needs to be measured. It also talks about when you are putting these different appliances on your patient, you need to know when to actually remove it or when to empty it, and it should be emptied when it's about 1/3 to 1/2 full. It talks about providing skin care, and with providing skin care, when applying or changing an appliance, assess the stoma and the skin around it to make certain there's no irritation, excoriation, or ulceration. Then use a soft washcloth, warm water, and mild soap to wash the stoma and skin. Rinse thoroughly and pat dry. It talks about providing emotional support. Do you think a patient who has a stoma would require emotional support? Because when I think about it, I know that's definitely it's a change in appearance, and depending on who the individual is, depending on how old they are, it can definitely affect the individual psychosocial being, where it can have an impact on how you feel about yourself. Having a stoma, having to carry around an appliance bed where stool pours into it. It can be embarrassing. It can be completely uncomfortable. And it talks about irrigating a colostomy. And typically with irrigating, you flushing that colostomy out. So maybe you're sticking some type of device inside the colostomy, squeezing fluid into it, um, and everything will pretty much pull out. What's there will pull out. It will actually come out. And please be clear that stomas can be reversed. For some individuals, they receive a stoma just to allow a certain portion of the intestines to heal. And some people who actually have a stoma, it's permanent. Make sure to read the last few pages. Make sure to reread all of the information. Make sure you understand the information that you are reading. The different terms you're not so sure about, or you don't know what it means. Make sure you are looking this information up. Make sure you are rereading it all.